having gone through this draft last night, I think I have 27 questions. I mean, that's just me. And I just wonder what the process is going to be for us to be able to offer all of the questions that we have. I mean, we have to get out of this room at noon. We don't meet again until whatever. But I'm just saying, this has, you know, they may be just clarifications, but I mean, I have 27 questions in my computer, which I document, which I can't find. I did count. 27 yesterday. But I'm so working memory now. But I just want to know that just hearing this presentation and then saying, okay, we're going to ask questions. I mean, I can't speak for anybody else, but I probably could ask, you know.
So the intent with today's presentation is a very high-level overview of the proposal. We will have a walkthrough tomorrow of the bill, taking us section by section. And even that is intended to be sort of a mid-level review. As a host committee, on that level, we will then focus on each component of the proposal with a more detailed walkthrough and testimony. So for today's purposes, I think the goal is to try to understand the general concepts. Tomorrow will be to understand what's in the specific sections. And then the third step will be to understand every detail of each section.
That helps me figure out, you know, so I won't all ask them. I just have one question from now is, because I read this in the report last night, and this is, I think we mentioned it a couple of minutes ago on here, and that is, when I think of municipal workers, that's people that work for the city. Am I to take from your presentation that you have a broader definition of municipal workers? Does that include teachers?
Yes.
It does. So when you look at a municipal worker, you're not just looking at people who work for the municipality, but including the teachers, all the school boards.
Yeah, all
okay.
the employees. Our concept is we would like everyone to be in the system.
Yep.
Obviously, there's details to be worked out in terms of how that happens, but our going in assumption is very different.
Look at the word municipal worker. Just raise the question. I'll hold my back now.
Well, if we're going to stay at 30,000 my basic question is, it looks like all power is ceded to this one board, and model that to the public service board, which the legislature just very recently didn't have any faith in to come to a decision on our energy future. So using that parallel, and this is the model that you chose, what makes you believe that this is going to work where we've had an experience in the past where the legislature didn't believe?
Well, I think you can find examples in the public service board experience that suggest that largely that model does work. But obviously there will be exceptions. And in any process like this where you're trying to set policy affecting, in this case, an even bigger portion of the economy than utility rates, there's going to be bumps and hiccups along the way. We don't expect that it'll be perfect, but we think that you need to create something that is outside, somewhat outside of both the executive and legislative branches, has the resources to really understand and analyze this issue in a way that we never have before, and has the power to make decisions that will move us towards something that's very different in terms of how we control healthcare costs.
Are you open to sharing the power of the department?
We'd consider. We're, at this point, we're open to all proposals that come from the folks. So,
Chris,
I appreciate the presentation, and I know a lot of work has gone into this, and I'm one of the people that are quite excited about this. And I really like your building analogy, because I've been thinking about it as along those lines, but never the building next door to the building we're living in now. I guess another analogy for me, though, that I guess I worry about is sort of the used car salesman analogy. And I feel like in a lot of ways the state has been a used car salesman that keeps saying, "Oh, this will be a great model for you," and when the public drives off in our latest iteration and it breaks down, a mile away from the lot, as it were. So I guess I'm wondering, I think there is a trust question that I'm worried about, and maybe more directly, while we're setting up some of the structural things, what is there in this proposal within 2 years that the public might see or feel in their life daily, that they experience that would help us build that trust? Because I think that's essential.
So I think that really revolves, I'll take the second part of that question first. I think what the public will see in the short term really revolves around the work of the board, and that's why the board is so important. I think they can move on two fronts to make a real difference. One is to work with healthcare providers to figure out how we put the state on a budget, and that will have, as soon as we can do that, that will have an effect on health insurance rate increases. We need to do that as soon as possible. It's not easy work, but we need to get it underway. In the absence of that kind of change in our healthcare system, insurance premiums will continue to go up the way they have been and the way they are everywhere else in the world. So we need to start to really fundamentally change things there. The other thing that I think will result from the board's work is much greater transparency in the healthcare system. So greater knowledge on the part of everybody involved about what's going on, what are we spending our money on, where can we reduce our spending, and how are costs distributed now. Something that your chairman points out a lot, that most people have no idea how much their health insurance costs now. So I think we can make a difference in terms of having greater knowledge and therefore going into the stages where we talk about financing with a much better baseline knowledge about what we can expect to save, what we should expect to spend, and how we should distribute those costs. The used car salesman analogy. I think we have three choices. We can do things in the way that I've described. We have a roadmap. We've got some stopping points along the way where you guys will be involved, and we have some clear structures we're building on. And we say, trust us to come back with more details and give you a chance to vote on those additional details. We can say, well, we don't want to deal with that whole framework because it doesn't fill in all the details, and we can try to fill in all the details, but I don't think that we can really do that responsibly right now. So we could build something that says it's going to all be like this, and then it probably will end up being a lemon. The third option is to do something far less dramatic in terms of its ultimate intent and do some sort of marginal incremental reforms this year. That's not going to change the world, and that'll just, it'll maybe make a little bit of difference, but it's not going to change the fundamental dynamics in our healthcare system, and so we'll be in the same place we are now.
Thank you for what you did. I think this is sort of monumental. Two questions. One, can we get the slides that you didn't give us? Can you make them a little bigger because we think you're having a similar, and I can't.
Yes, actually, I should point out that everything in my presentation is on the governor's website now. We actually just checked. I also should point out that a very helpful member of the audience pointed out that my very first overhead, which shows the health spending, back in the beginning. This is wrong. Health spending didn't double between 1992 and 2009. It doubled between 2001 and 2009. Between 1992 and 2009, it looks like it about quadrupled. So I apologize for that mistake, but the problem is even worse.
And that wasn't my question. That was my question. The question was, and I think it was one of the last slides that you showed, it had a box, which was the only box that I saw off into the future that had the legislature. And a lot of what is being proposed that the board does, and again, I'm doing this based upon just today's presentation and not having read what you wrote, just rate setting and global budgets and so on. At some point, I would think there have to be appropriations of these monies and the role that the legislature plays in setting reimbursement rates and so on. So could you elaborate on what the legislative role is ultimately after we've given this responsibility to an outside board, but ultimately the implementation has to come through the legislative process, at least to write a check?
I can say a couple of things, and then I know Ken and Robin may want to say more. So the legislature is involved in decision-making at each stopping point along the road. So, 2012, you look at an integration plan and say, does that make sense to integrate these populations through this exchange? In 2013, you look at financing plans and say, does this make sense? In terms of the ongoing role, and then beyond that, if you move to a publicly financed system, the legislature is much more involved in ongoing decisions about overall financing. Short of that, the legislature continues to have a role in terms of Medicaid policy. And so the idea here is that the board sets overall policy about reimbursement and, very importantly for Medicaid, figures out how to move away from cost shifting. So it's something where everybody's paying a fair rate. But the legislature still has to make the appropriations that are driven by those payment decisions.
So it might be more like the school board, the State Board of Education that is recommending rates for property tax, say like property tax, but ultimately the legislature will have to decide to go along with that. Okay, thank you.
Yep.
I was just hoping, honey, that you would clarify what is meant when we are integrating Medicare through a waiver. It's only the payment process, right? The program itself would
Ultimately, if we have the publicly financed system and wanted to enhance Medicare benefits, that is something that we could look at under Medicare waiver as well. Medicare benefits are not the greatest in the world, and so if we're going to try to have a common benefit plan across everybody that is adequate, that may be something that we want to finance through savings. So that'll be an issue to look at in terms of Medicare integration. Shorter term, what's really important is Medicare integration in payment reforms, because Medicare is such a big piece of healthcare financing. And as we've seen with the Blueprint, for example, including Medicare in the payment methodology for Blueprint practices was very important to being able to have those practices have a critical mass of changed payment that really changes how they do business. And as I said, there are different ways that we can integrate Medicare. We're looking at those now. They range from the state can be a Medicare risk plan, which is like we essentially, like with the Medicaid waiver that we have now, we're going to take all the money and manage the full pot ourselves, all the way down to something where we expand the margins of the Blueprint and have more services included in that waiver. And then there's a whole lot that can be done on the provider side, where providers can go to Medicare and say, here we are as 3 hospitals, 4 hospitals, and a bunch of physician practices, and we want to take a budget from Medicare or take a risk-sharing arrangement from Medicare that's different from how you would pay us fee-for-service. And if we manage under that budget or under that risk-sharing arrangement, we get to save some money. The idea of all this is not only that you get to have smarter reimbursement through Medicare, but also that the state can realize and providers can realize some of the benefits of saving Medicare money. And since a lot of the real high users of healthcare are covered by Medicare, there's the potential for a lot of savings there. But when we save the money now, it goes to the federal government.
Just to clarify, in terms of those who are on Medicare, they would maintain all the benefits that they currently receive right now?
Yes, there would be no change from the beneficiary's perspective. And in fact, Medicare won't give you a waiver that restricts choice for Medicare beneficiaries or changes their benefits.
Anthony? No. George and Anita?
Surprise, surprise.
Here, George.
Yeah, we're both closed.
Yes, I think we are. I appreciate the work you've done on this. I know you're all working very, very hard on this. To add to Representative Pearson's remarks, I think there's trust problems with the public. There's also trust problems with the provider community and with the business. So starting with that as a background, I understand the government's desire to do something dramatic. And I also understand that we would like to have us finish our work on this bill by the week after town meeting, which is not very far away. I understand the urgency of moving forward with the exchanges because the need for being made very quickly. I don't understand exactly the urgency to move forward with the rest of it. So I wonder what the board adds this year that we're not doing. I mean, we have a blueprint. We just appointed a director of payment reform who's working on the integration of care issues. So I'm a little bit wondering, what the urgency with establishing this board is. I want to go back for a minute to your analogy. So we have a building we're in now. We don't like it very much, but there's going to be a building next door. And it's an expensive building. We're talking about a $5 billion building. And when I think of the healthcare system, the foundation, I had to say, what are the four corners of the foundation? I would say that you have the financing is one of the corners. The delivery system is another of the corners. Health information technology and the payment system. Those are all the corners of the foundation. But it feels like what we're being asked here is to sign on to a lease for this building without the foundation being built, without ever seeing the blueprint for the entire building. So I just wonder at the 3,000-foot level, what is the urgency of doing the building now, starting down that road? What does that add?
The urgency is that we need to control the cost. And we need to do that in a much smarter way than we've ever tried to do before. And that involves work that has to begin now with healthcare providers to figure out how we can pay differently and put the state on a budget.
I'm sorry, I didn't understand the difference between how the board's going to do that from our payment. The person who just started a new position this year, the payment reform director.
The payment reform director would be part of this effort, but we think that it needs a lot more horsepower than just one person, and that it also needs a lot more integration with current regulatory processes. So how do we fold in, what do we do with the hospital budget process and the insurance rate process as we get more knowledgeable about the effect of payment reform on healthcare costs. So we see this as something that has to bring all that policy together and make sure that we're moving as quickly as possible towards something that controls healthcare costs and controls healthcare costs in a rational, reasonable way, rather than, there's a board like this in Maryland, for example, that does rate setting, but they do it on a fee-for-service basis. It's better than, I would say, better than what we have here in Vermont, because it at least deals with cost shifting and says everybody's going to pay the same amount. They have a Medicare waiver way to do this. Everybody's going to pay the same amount. There's a lot more transparency about costs, but it's done on a fee-for-service basis. But it allows them to get a handle on total hospital spending in the state and have a much more rational conversation about how costs are distributed. This is something that's broader in scope, so it includes more than just hospitals, and hopefully it's done in a way that changes that basic payment incentive so that you're moving away from paying for volume and toward paying for value, paying for outcomes. And that is work that we feel needs to be well-resourced, needs to be set apart from other parts of state government so that it has clear authority, and needs to start right away.
But you understand the analogy that I'm making with the building. You're not ready to tell us yet about payment reforms. You're not ready to tell us yet about financing. You're not ready to tell us yet about the you're being asked to sign on.
The payment reform and delivery models are what the board would do. That is the work that the board would be undertaking.
Just want to remind folks we have 5 minutes before we need to be done, so a few more questions.
You keep using the word rational, and rational has ration in it. Do you see, no, I mean, I'm talking, do you see that the Vermont Healthcare Reform Board will really be taking on global budgets that allow us to spend so much on what we need to do for healthcare, i.e. prevention, good habits, all that stuff. Plus, this is all medical care, how we pay for it and all that stuff. So it would seem to me, if we're partners, it would seem to me that the parameters and criteria for the Vermont Healthcare Reform Board, not only to outline what their job is, but also to get some safeguards of coming back to the legislature so that it is, and I don't totally understand the Public Service Board, but I think that's the beginning of a model, but it's not the end of the model. Our creativity of partnership has to be how we do this legislation. So I'm not sure, I mean, what's very scary and interesting is that we don't know the 4 pillars, and you keep saying that. And we're moving into this knowing the end result of where we want to be, but not knowing the journey there. And we as legislators have to make sure that the legislation allows us to be part of each stopping point, I think. That's where, so that's just a statement. And then my question is, in order to bill this as health care and medical care, do you see any room for prevention, diet, food, all the stuff that makes us healthy? Do you see any of that being able to put into the healthcare exchange system? Like, where do you get healthy fruits and vegetables? Where is free yoga classes? Where are blah, blah, blah? You know what I mean? But because this is a medical thing that we're doing. And so I'm just worried that prevention and all that stuff is going to be an afterthought. And I'm very hopeful that it can get into